Everybody. It's nice to have all of you here. I say good morning because this is Jerry Roth, president of UIA, and I am sheltering in place here in San Francisco. We have speakers from all over the world today, from Japan and across the United States, and from Europe as well. So it's different time zones for all of you, but morning here in San Francisco. Thank you all for being here. As many of you know, during these difficult times, I am really proud of how UIA has adapted. We've been putting on webinars virtually every week, sometimes several times a week, including this one, and I'm very grateful to our speakers. We have podcasts available, we have LinkedIn exchange sites available. We've been putting out videos and other types of online events. I thank all of you for joining all of these and for participating and supporting UIA during these difficult times. I think it plays a critical role in bringing all of us lawyers together so that we can work jointly and face the new realities. With that, I'm going to turn it over to the panel, to Janice Mulligan, who's going to be the moderator this morning from San Diego. I wish all of you a wonderful seminar. I will be clicking off my little screen here in a moment, but I'm very grateful to all of you for being here and for working with us through this difficult time. Thank you very much. And Janice, it's all yours.
Thank you, Jerry. Good morning. We have a wonderful panel of both physicians and lawyers with us today, so I'm just going to get started and I'll introduce panelists as it's their turn to speak. We are having some technical difficulties with one of our panelists this morning, Josh Cohen in New York. So we will advance through the slides and go to Dr. Takahashi's presentation first, and then we'll return to Josh Cohen's slides when hopefully he'll be able to join us on the screen. Our first speaker then, Dr. Shigeki Takahashi. I am proud to call my mentor as well as my friend. Dr. Takahashi is from Tokyo, and he is both, as I've mentioned, a physician, a lawyer, and as though that it wasn't enough training, he also has a PhD in public health. Dr. Takahashi is a member of the law firm of Hamani-Takahashi in Tokyo. He's also a lecturer at the medical school, Santa Mariana Medical School, and previously at Tokyo Medical University. Without further ado, I give to you, Dr. Takahashi. Thank you for joining us. I understand, Doctor, it's what, almost midnight for you in Japan?
Yes. Thank you, Jan. Can you hear me?
I can hear you well, Doctor.
So how can I?
If Colette could advance the slides to Dr. Takahashi's presentation, it would be appreciated. There we go. One more. Thank you.
Yes. Hello, everybody. I'm talking from Japan under state of emergency. However, the number of patients and deaths are not so large or small, we can say, and we do not have a lockdown, though we are under state of emergency. You might feel that the current situation in Japan is strange, but it's not fabulous. Today, I'd like to explain the background of this strange situation. Next slide, please. Yes, this graph shows the cumulative infection number of COVID. You can see Japan on the second from the bottom. So why is the number of infections so small? The answer is very simple. That is just because the number of PCR tests are small. Next slide. The population of Japan is over 120 million. However, the numbers of PCR tests are only 200,000, whose number is less than 1/10 or 20th of European countries and the United States by population ratio. And this number includes the second or third test to judge the condition of discharge from hospital. So the number of persons who have taken a PCR test is smaller than this. Next slide. Yes, that is why the battle against COVID in Japan began suddenly on February 3rd in this year, when a cruise ship named Diamond Princess docked at Tokyo Harbor. In this ship, there were 3,711 passengers and crew, and totally 712 persons had COVID. the government put emphasis on tracking of close contacts of disembarked, and when a cluster of COVID occurred, they made an effort to identify the infection source in order to stop epidemic. In this purpose, it is enough to perform PCR tests to those who have a possibility of infection. In addition, the sensitivity of PCR test is rather low. I'd like to go to next slide. Yes. Suppose there are 100 infected persons among 10,000 inhabitants, and sensitivity means how many percent of the infected is identified positive. The sensitivity of PCR test is reported less than 60% from collected swab samples from nasopharyngeal. This is because coronavirus does not necessarily multiply in nasopharyngeal membrane cells, but it can also multiply in lung membrane cells or intestinal cells. It is a common case that the sample collected does not include coronavirus. So suppose the sensitivity is 50%. 50% of the infected are identified positive, and they are obliged to be under health surveillance. On the other hand, we have the same number of false negative inhabitants who are actually infected but identified negative. They may misunderstand that they are healthy and enjoy city life without any restrictions. However, they have the ability to spread COVID, so PCR test is not useful to exclude non-infected. We have already several cases that the close contacts who have identified negative transmitted COVID to their family members. In this prospect of epidemiology, the antibody test is more ideal. However, we had not yet a perfect one at present. Next slide. So this is the reason why the government is reluctant to carry out PCR test for all inhabitants. And we only had an administrative route of PCR test through local public health centers till recently. It may be theoretically correct to narrow down the test target to close contacts. However, as the number of suspected infections, as well as the number of infections of unknown route increased, we are confronted with the severe lack of material and human resources. And there was no choice but to wait for a week or more for the test to the necessary subjects. The administrative route is extremely insufficient to meet demand. Furthermore, as the total number of PCR tests is so small, we cannot estimate how many inhabitants in Japan have COVID. We cannot estimate the effective reproduction number, which is necessary to evaluate the effect of health policy interventions, such as isolation, and we cannot predict the future epidemic either. Under this situation, as the local medical associations, which are a voluntary group of local general practitioners, began to establish temporary PCR clinics in the parking spot in front of the hospitals recently. Now we can test without going through the public health center route, but it's too late. Yes, next slide. We have the Act on Special Measures for Pandemic Disease. This act was established in 2012, anticipating another new influenza pandemic. In February this year, this act was amended to enable application to COVID. According to this act, the Prime Minister has the authority to declare a state of emergency, and actually, Prime Minister Abe declared it on April 7. He prolonged the declaration till the end of May. Under emergency state, each governor has the authority to demand avoiding unnecessary outings to citizens, and also limiting the use of facilities to managers, but they are only demand, which are not enforceable. In case citizens would not comply with the demand, there is no sanction at all. And in case the manager would not comply with that demand, the governor is capable to instruct to comply with it and announce the facility name to the public. However, there is no penalty if when the manager to reject the instruction flatly. Some of you may think that these measures are ineffective and we should adopt a lockdown. However, we Japanese dislike of the government's exercise of power on the historical reasons, I think, which remind us of the repression to the people during World War II. Especially in the health field, this dislike seems to be stronger as the Minister of Health continue to implement stupid policies that were criticized by posterity, such as a needless isolation policy of Hansen disease till 1997, and forced eugenic surgery to mentally and intellectually disabled till 1995. On the other hand, we Japanese are apt to attach importance to harmony, which means that we are less reluctant to do the same as people around. At the declaration, the government announced that it was necessary to reduce the person-to-person contact by 80%. It was reduced by about 70% by citizens' voluntary cooperation. We have only a few facility managers who have rejected the demand of the governors. And next slide shows, Yes, next slide shows the number of deaths and rate of deaths of COVID. The number of deaths and the rate are far smaller than the United States and European countries. We can say that the medical care system in Japan is well functioning now. Next slide. The left graph shows the number of beds for acute care in hospitals that each country has. Japan has the most beds in the world. Then, why do we apprehend the overwhelming hospitals? Please look at the right side, light graph. It shows the number of ICU beds. We can see easily that ICU beds in Japan is even fewer than in Italy, Spain, and France, where the damages were severer. So we can say that Japan's emergency medical care system is very fragile. Next slide. We have an abundant supply of beds for we have an abundant supply of beds for acute care. However, these beds are titular only by name. In Japan, we do not have clear discrimination between beds for acute care and chronic care. And 80% of medical institutions are small local private sectors. They have beds for acute care, but the reality is that the chronic stage patients are hospitalized as acute phase patients, as medical fees for acute patients are more rewarding. A political pressure group named Japan Medical Association was organized, which has strong political power and always try to maintain their vested rights. They are reluctant to implement telemedicine, as it expands the range of medical institutions that patients can choose, which means that small local private sectors lose their neighboring patients. After the pandemic of COVID, we discussed the necessity of telemedicine, but it has been approved only under several strict conditions, such as the limit of the application to patients that are treated face-to-face more than 3 months. And the rewarding is almost half of face-to-face treatment. The unexpected pandemic has exposed weakness in Japan's medical care system, and we must consider how to correct this weakness to the second wave of COVID. Thank you. Thank you for listening.
So Dr. Takahashi, if I understand you correctly, it's not a lack of infrastructure that's preventing the use of telemedicine. It's the rules and regulations, such as you have to have been a patient for 3 months before this can be initiated?
Yes.
Is there any attempt
It's impossible to do it at the first sight patient.
And is there any attempt to change that now?
About telemedicine?
Yes, sir.
Yeah, before COVID, there was one more conditions. That is, a physician can approach to the patients within 30 minutes. But this condition was avoided. It's impossible. Most of the cases, it's not so easy to reach at the patient's place within 30 minutes.
Well, I'm sorry to hear about that, because as you know, we'll be hearing of other experiences where some of the other countries have had success with telemedicine, most notably the US. Josh, should we go on to your presentation, or should we go on to Dr. Friedman's on telemedicine?
It's up to you, because.
Oh, we hear you now.
Yes, I finally figured it out. Took me a little while.
So Josh, can you see your slides?
Yes, I can.
All right, very good. Then why don't we go ahead, if I may. I'd like to introduce to you our next speaker and say that just as I have had the privilege of interrupting at the end with questions to Dr. Takahashi, for those that are online, if you could please.
I lost you on audio.
You lost us on audio. We can hear you. While he's trying to regain that, I'm sorry for the
Hold on, let me switch.
difficulty. I would ask that any of the people that are on the seminar with us today, feel free to write in
I am
questions.
not hearing you right now.
We will go on to Dr. Larry Friedman.
Jen,
Yeah, we can hear you.
I'm not hearing you.
All right. If you would mute me, we'll go on to Dr. Friedman.
You can hear me?
We can hear you.
I can hear you.
Okay. Let me just tell Josh we can hear him. And then I'm going to introduce Dr. Friedman. Okay, so I let Josh Cohen know that, and hopefully we'll have the audio and visual portion regained with him in a few minutes. It is absolutely my privilege to introduce to you my good friend and excellent doctor, Dr. Larry Friedman. Dr. Friedman is the CEO of International Patient Services, and he's the Associate Dean of Clinical Affairs at University of California, San Diego. Dr. Friedman works closely with foreign embassies, health ministries, and insurance companies to ensure that individuals worldwide have access to clinical expertise that is offered by San Diego Health. As a professor in the School of Medicine, Dr. Friedman is involved with training our next generation of physicians and works closely with physicians locally and around the world on topics such as IT and telemedicine. Dr. Friedman co-founded the UC San Diego telemedicine program, and he's guided its growth throughout California and into international locations. Without further ado, Dr. Friedman.
Thank you very much, Jan. It's my pleasure to be here, and it's my pleasure to be on such a distinguished panel. This is one moment in history that I think survives where doctors and attorneys work together hand in hand to solve a common problem and a common pandemic. So I organized my talk into the good, bad, and the ugly, because it's a very American thing to do. And my perspective is going to be primarily about the US, the United States experience, because it's what I know the most about. So, trying to think about what good is either coming out of the pandemic now or will come out of it. Clearly, as time goes on, there will be a vaccine, there will be treatments. There will be more than one treatment. I'm optimistic about that. And then with any advancement in vaccine research, there will be spillovers to breakthroughs in cancer, cancer care, and other viral mediated diseases. That's going to be an advantage for us all. In the public health field, we clearly are learning a lot in the United States about what works and doesn't work. And there have been regionally very effective public health endeavors, and I would say that San Diego has been moderately effective in its public health approach to this pandemic. Internationally, there have been some terrific examples. New Zealand is the one that comes to mind, where they've done a great job containing the pandemic, at least so far. And I think it really highlights one of the most important parts of, I think, part of what we're all going to talk about, which is the politics of this healthcare crisis. Medically, there have been incredible acts of valor and dedication by healthcare workers all around the world, and it's really it's more than just impressive. It's really awe-inspiring how much dedication has been put into taking care of people who are acutely and extremely ill. The internet has allowed instances of sharing of medical information around the globe instantly. So one of the advantages right now that we have is that there's really no holding back in terms of what we know as fact about the virus and about what treatments are working well and what isn't working well. They, of course, all require randomized controlled trials. So, but the fact is that when something seems to be working well in Italy, that's almost instantaneously transmitted to medical colleagues around the world. New technology and applications, mobile devices, applications of artificial intelligence. In my organization, we have actually patented a technique for using artificial intelligence to identify the patterns of COVID-19 pneumonia before they become visually apparent to radiologists, and that was done through artificial intelligence. And there are other examples also. Contact tracing through mobile devices like Google is trying to or has talked about using, and then rapid deployment of telemedicine. Now, telemedicine is not a new technology, but the rapid deployment of telemedicine, at least in the United States, has really grown tremendously in the last couple of months. So what were the catalysts in the United States for telemedicine growth, or what were the motivations? And the main motivation was policy, not technology. As I said before, and I tell all of our telemedicine partners, technology is never a barrier to telemedicine. There are a lot of different vendors, there's a lot of different equipment, there are very sophisticated telemedicine systems. We're all used to, frankly, using some kind of telemedicine ourselves personally, Zoom, FaceTime, Skype are all non-secure forms of telemedicine. So what happened in the United States that caused the explosive growth? And I'll show you the example of the explosive growth. The main catalyst was that Medicare, which is the Centers for Medicare and Medicaid, which is a federal government reimbursement, issued a waiver to pay for telemedicine. Prior to the pandemic, they were not paying for it. They were not reimbursing health systems or doctors for telemedicine visits. They also issued a waiver for telephone visits. And they also issued a waiver for cross-state lines. So you may or may not know, in the United States, doctors are limited to practice only within the state in which they have a license. So I'm in California. I actually, if I had a patient who wanted to see me in Nevada, I would need to either work in partnership with a Nevada physician or have my own Nevada license. So the government, the federal government, also waived the state boundary limits. Now, these are not laws, these are waivers, and it'd be interesting to see, based on the government's experience, how many of these waivers remain post-COVID. Social distancing also really was a catalyst also. Almost immediately, and I'll show you examples in my institution of how quickly this happened. As soon as the governor of California issued a social distancing and shelter-in-place regulation, patients didn't want to come to the doctor, and the doctors, frankly, didn't want to see patients either in the office. It was clear that there was a significant danger to both patients and to doctors for getting together, and that created a motivation on both the part of the demand for telemedicine, demand by patients, and the supply by the doctors to come together to work on this. So as I said before, there's not a lot of new technology, but new and broader applications are definitely coming into place. So this is, I'm not going to go through this in great detail, but this goes back to November. This is actually a collection of all the University of California campuses. So San Diego, Los Angeles, San Francisco, together, collectively, the University of California system takes care of about a quarter to a third of all people living in the state of California. And you can see back in November, to the bars on the left, you can see November, early March, there was very little telemedicine collectively across the campuses. March 19th, there was a statewide shelter-in-place order put into place. And you can see the rapid growth, almost up to 50% by the end of March, beginning of April. The number of visits, these are all outpatient. So these are all outpatient visits in the state of California by the University of California system. So it went from virtually zero to almost 50% in just a couple of weeks. That's pretty astounding. And I can tell you, within the University of California system, there's some variation amongst the systems, and there's great variation among specialties. So here's a slide in my specialty. This is internal medicine primary care at my home institution. This is actually my division that I'm the division chief over. And this is week by week, we keep track of the number of visits being done by face-to-face, by telemedicine, and by telephone. The blue bar to the left is what our expectations were at the beginning of the year about the number of face-to-face visits we would have in this specialty. And you can see this is a weekly tally of the number of visits we're having in our clinics. The horizontal bar the yellow bar is the 75th percentile, the red bar is 100%. And you can say, this is the most recent slide I have, which is April 20th. you can see that we're almost up to 75% of our predicted visits with the I don't know if you can see my arrow, but the gray area here is telemedicine visits. The orange down at the bottom is face-to-face. So we're still doing some face-to-face visits. Telemedicine doesn't take the place of everything. And yellow is telephone.
I'm sorry, yellow's what?
Telephone, which is usually, so, you know, one of the challenges with telemedicine is from the physician end, from the health system end, we have a pretty organized system for making sure the doctors know how to use telemedicine, and they have to actually get certified as having been trained on it. On the patient end, and we have a variety of patients, there's an issue of, do they have the right hardware? So do they have a laptop or even a cell phone? Do they know how to use the application for telemedicine? And in some cases, do they have an internet connection? And so if all of those fail, the fail safe is just pick up the old-fashioned telephone. And in some cases, you know, it's worked. That's been sort of the fail safe. So what are some of the bad things that have come out of this? Lots of competition, but questionable collaboration amongst researchers. That's unfortunate, but you know, everybody's competing for a variety of reasons, and I won't go into that. I think they're probably somewhat self-evident. Propagation of false claims about unproven treatments. I don't know what that's like around the world. I will talk about that in a minute. In the United States, it's really quite disruptive and harmful. Public health departments caught unfunded and unprepared, or underfunded and unprepared. That, to a large degree, was the case in San Diego County. And decisions are often political and not public health supported. Again, I think that's as much a national issue as it is a local issue here. Medically, the workforce sometimes is afraid to go to work and often way understaffed and sick. I think that's been more of a problem in larger cities where the pandemic has been way more harmful, like in New York City, than it has been in a place like San Diego, where our infection rate has been relatively moderate. Professionals are forced to provide care when they're not experienced or fully trained. I know, in some cities that have been the most hard hit, before even graduated from medical schools, doctors, really fourth-year medical students, are thrown into the front lines. Residents are being asked to work in intensive care units when they're really not properly trained to do that. And in some locations, there's lack of equipment and proper space for that equipment. And there's been just a huge financial strain on the health system, which we have not even begun to feel yet. Let me just for a second explain that. I'm not sure how much that resonates in other places around the world. In the state of California, and I think this is the case in most states, we were asked at the very beginning, as we watched what happened in New York City, to make half of our beds in our hospital available, assuming that there was going to be a surge of COVID patients in San Diego. We stopped elective surgeries. We emptied out the hospital of people who didn't need to be there, who could be transferred to chronic care facilities, and half of our hospital and our intensive care units stayed unfilled. That's a huge financial strain on the healthcare system, which we had to absorb. We locally in our hospital had to absorb. We're hoping that the federal government and the state government will help make some of that up. We've gotten a little bit of federal money yet, but nothing even close to making up the cost. It's like a hotel or an airplane every single day having half of your seats or half of your rooms empty, because we're waiting for, frankly, a surge of patients, at least in San Diego, which never happened. So the ugly, and there's been a lot of ugly in the United States, and I guess I will try not to hold back because I don't really care. So there's you know, one of the most essential things for a public health system and a government to work is trust. People who trust their governments and their leaders, I think, are much more likely to pay attention to them, will follow directions, and really sort of work as a collective. In the United States right now, there's a huge lack of trust, accountability, and competency at the very highest level. You would think that with a common threat like a pandemic, it would bring the country together, but in fact, it's actually split the country. And that's very unfortunate. It split the country nationally, and it split the country in states. I don't know, some of you probably see it on television. The protests in some areas have been in San Diego, people who want to basically eliminate all the public health measures, go back to normal, start working again. And some of those protesters, are come armed with guns, a very American phenomenon. And it's very scary that because of a mixed message at the very highest level, there's a mixed response by our population. There's a lack of central planning or organized coherent response. Barack Obama, I think, appropriately described the White House currently as in total chaos regarding COVID-19. I think he's absolutely right. States are making decisions without federal principles or guidelines. I think that in many cases it's proper for states to make decisions because all issues are local, but they're doing it without guidelines from the federal government or even the Centers for Disease Control, which is really the federal public health organization that really has traditionally been really the central repository for public health guidance. There's chaos in some regions, including nationally, as I said. There's lack of testing, tracking, and protective gear. Testing is getting better. In places like San Diego, we pretty much have widespread testing now, but it's taken really just until a couple of weeks ago, and there are parts of the country where testing is still a major problem. In terms of medical, and this is something that we really have not yet seen, but is coming, and this is going to be one of the most ugly things. Our unemployment rate right now is up to almost 15%. It's expected to go to 20% or higher. Many of those jobs come with insurance. People are going to lose their jobs. They're going to lose their insurance. In the financial crisis of 2008, there's a lot of data that when people lost their jobs and their insurance, they also delayed medical care. Things like mammography, things like colon cancer screening, things like vaccines. And when they finally did come back into the healthcare system, they were extremely sick. Many hospitals, at least some, I don't know if many hospitals, and especially medical offices, will go out of business. I have no doubt about that. And people are afraid to go to hospitals and emergency rooms. And there's recent data showing, and this was the case in our hospital too. People are having, for some reason, the rate of people in San Diego having heart attacks dropped precipitously. And it turned out, and that was because they weren't going to emergency rooms. It turns out people were having heart attacks and dying at home because people were afraid to go to the emergency rooms, thinking that they were just going to get infected with COVID-19. And that's a national phenomenon, not just a San Diego phenomenon. So what hopefully will the future bring? A return to trust in government and public health. History will judge the U.S. response harshly, and harshly is probably polite. Hopefully we will have a return to globalization. We're all connected, and clearly us all working together on a common enemy such as this pandemic. We've learned lessons about that. There will be a new debate in the United States, I think, about insurance coverage for all. There'll be a widespread adoption of telemedicine and remote monitoring in the United States. And I think to a large extent because patients like it. They found out that, you know what, you don't need to take a half a day off from work to go see your doctor for many issues. You can do that from your home or your office. There'll be new knowledge of viruses, prevention and treatment, role of federal versus state and local public health decision-making, I hope will be worked out. And hopefully, as Diego and I have discussed, in the near future, we will be drinking wine rather than bleach. So, I think that this slide sort of says it all in the United States. We have a president who on TV most recently said that the virus is just going to go away without a vaccine. And 2 weeks ago talked about injecting Lysol or other disinfectants such as bleach as a possible treatment. Why not just try it, was what he said to people like Dr. Fauci, who's an incredibly well regarded, respected health official. And, depending on where you get your news in the United States, you may listen. By the way, when Trump said that, poison control hotlines were flooded with people calling to ask if that was actually okay. The fact that they even thought it was okay to call a poison hotline says something about some people in the United States. So I will leave you with that, and hopefully the U.S. is heading much closer to the Fauci era than the Trump era, and we're going to need to wait for a next election to hopefully work some of these things out. So thank you very much for listening. I hope I didn't go too much over time. I look forward to your questions when we're all done.
Thank you, Dr. Friedman. And we have one comment from Ken Fields who says, great slide. I assume he's talking about the last one. I don't know. I kind of like the slide that said, let's drink wine, but I'm half Italian. Maybe that's why. Thank you for your presentation. Josh, are you available? We can't hear you. Oh, you're muted.
Can you hear me?
Yes.
Now I can hear you, so I will introduce you if I may. So Colette, we're going to go back to the beginning, if you will, with Josh's slides. It is my privilege.
I'm going to quickly, because I think many of the other commentators have already summed up what I have to say. But,
Okay.
you know, are you controlling my slides?
I'm going to introduce you first, if I may. And then we'll let you go. And I will say that you were to deliver your presentation first, so I understand some of your slides are basic information about what telemedicine is. Let me say, however, that having worked with you in the past in far-flung places like Budapest and New York, and I know you're a trial lawyer, so there's no doubt in my mind that you're going to find very interesting and unique things to say during your presentation. Even though you and I are somewhat on opposite sides of the law, if you will. By that, I mean that Josh is a founding member and senior partner in a medical malpractice defense firm. He's both a trial and appellate lawyer representing hospitals and physicians in litigation, administrative hearings, and investigative proceedings. In addition to being the secretary for the UIA Health Law Commission, thank you. Josh is past president of the New York State Medical Defense Bar Association, recently appointed as chairperson for the Association of the Bar of the City of New York Committee on Medical Malpractice. And I don't mean to make fun of you given you had technical difficulties today, but I understand that you are also a member of the New York State Court System on e-discovery working group. We know you have technical skills that are mad and crazy, but the new norm is to have complications in our daily life. I turn
let's just get to it.
Okay,
let's. Who's controlling my slides?
Either you or Colette.
All right. So before we get to telemedicine or telehealth, with you know, I do believe this. There is still physical medicine, and that's why I need to see a physician. So Dr. FRIEDMAN, you know, I need to see you. But at the same time, I'm not looking to supplant. I'm looking to, you know, make it easier so you don't have to worry about me and giving you a disease. I actually had a thermometer. I have a blood pressure cuff. I have a weight scale that I'm not going to bother bringing up here for you. Diego's going to tell me my hair is bad. But at the same time, for 80% of the things that you need to know about me, I can give that to you electronically. But by the way, you know what? I miss the days when a doctor took my pulse. He put 2 fingers, not a thumb, on my wrist, or she, and you know, we work forward. So tele comes from the Greek word from far and distant, and that's how telehealth came about. So it was talking about doing things from far and distant. If we can advance slide, or I'm going to try to do it. I can. That's why we have telegraph, telephone, you know, television. It meant distant or far. But the most important thing is I'm connecting with people from over 10 time zones. And I'm learning from all of you. I really am. And I really do appreciate it. Dr. Shigeki in Japan,
Yes.
You're up very early in the morning, but
No.
you know, I'm learning from you.
Ah,
So
can you hear me?
can you hear me?
Yes, yes.
So I do not, I am not very good at language, as you can tell. You speak better English than I do. But at the same time, I do wish you a good morning, you know, in Japan. So, you know, we need to tele from a distance connect. And that's what we're doing right now. We are teleconnecting from 10 time zones. And Jan is setting up something where I think we're going to be able to connect over, you know, the entire globe, which will be fantastic. So digitally, yes, we are talking digitally. And by the way, that is my name in digits. But at the same time, you know, we need to slow the speed of the virus. By the way, the virus is SARS-CoV-2. The disease is COVID-19. Now, that may seem a little simplistic, but when you look at the contracts, insurance policies, and everything, that will make a difference, at least here in the United States. I don't know about the world. I'm learning, though, thanks to this group. So the virus is SARS-CoV-2. The disease is COVID-19.
Josh,
And
the way you explained it to me before was very helpful about AIDS and HIV. Can you explain that?
yes, HIV was the virus. The disease was AIDS. So therefore, you know, when legally things are written, you know, one was HIV, the virus, and you know, whatchamacallit, AIDS was the disease. Now, I don't know what this means to the other world, not the other world, but to the world. But here in the United States, my little microcosm. By the way, my hands look really big. It made a difference here. And I'm going to be quick because I don't have much time. So therefore, what is the platform? So if I want to talk to Dr. Shigeki and I need a checkup, or Dr. Friedman, that I want to have a checkup, you know, I can show, you know, what are the platforms, the internet platforms being used for telehealth. And that's still in development. And they are getting sorted out. And first of all, we all need to be safe. We all need to be private. And we all need to be, the honest answer is, somewhat secure. Because right now, there is so much hacking and everything going on that I can't guarantee you security. But at the same time, you know, we have to be reasonable, and that's what we need to do. We have to build back trust, because you know what? There's a lot of people right now trying to break down trust. So, you know, we need our physicians and we need our healthcare providers. And we're very fortunate that we have so many great people right now on this conference call. And I trust them because if, when I need something, by the way, Jan sent me surgical masks from California. And, we have to build back trust. So I'm going to be very quick, as I promised you. There are licensing issues. And in New York, where my little microcosm is, and you may have heard it's a bit challenged, but at the same time, I want to thank all the healthcare providers that have come here physically, because by the way, we have physical medicine and we have telehealth. So the physical medicine, we have people who have come here from around the world to help take care of us. And I can't tell you enough as a New Yorker that I can't thank them enough. But they're phenomenal. But there are licensing issues. But by the way, that has been waived in New York a lot. Now, I do not know with all the different localities where everyone else is. And Jan's going to give me the 10-minute warning in a second. There are borders and boundaries. And borders are lines on a map. And there are many lines on a map. And, politicians, people in government, whatever, have had to waive those borders to make sure that in New York and other places where Diego is, that we've had to be able to get help that we need. And that's the key, help. Boundaries are moral. And, people have crossed boundaries, but you know what? They've done it to help. And that's a different issue between legal and what's right. Honor thy neighbor. Matthew, someone's going to correct me on this someday. 18 or 19, I don't know. By the way, I'm Old Testament. So, but we are all in this together. And that I do believe to be true. And I'm almost done, I promise. You know what? How are we going to pay for this? We call it reimbursement here, but how are we going to pay for this? Because, by the way, I'm going to look for, Dr. Takahashi or Dr. Friedman and say, how do I look? And I already know the answer to that. But at the same time, you deserve to be paid for your work. And that's what we're doing right now. New York has brought in 95,000 volunteers. So, we have to figure out a way to pay for this. So moving forward, and I'm almost done, I promise. My 10 minutes are almost up. You increase the use of telehealth to make it better for, I can promise you, no one has got a virus from this conversation. And by the way, there's a phrase, and I don't know if it's universal, but I'm sure that thanks to this committee, that I will hear, if an apple a day keeps the doctor away. By the way, I don't want to keep the doctor away. I want the doctor here, or well, not here, but I want to be able to communicate and do it safely and physically and legally, because we have a lot of insurance issues. We also have legal issues. By the way, New York, I can only talk about New York. I wish I could talk about the world, but to be quite honest, I can't, because I'm a little bit overwhelmed, to be quite honest. But, there are many legal issues regarding our boundaries, actually our borders. And, but you know what? I never thought I wanted to see a doctor more than ever. So to close out, telecare from far away, telesafe, I want everyone to be safe, and telewell, I want everyone to be well. But by the way, we're not having a teleconference, we're having a webinar. And web is an old phrase that comes from people coming together. It means woven or weaved or something like that. So therefore, I'm looking just to bring people together for the better good of the world.
Thank you, my telefriend. Now, we have some questions. We're going to wait until the end. We have one more speaker, a very distinguished speaker, so I'd ask you to stay posted and submit more questions, please.
Can I fix my collar?
You can fix your collar. Our final speaker, and I'll ask Colette to please go to his slides, is Diego Saluzzo, another good friend. Diego is a member of Grande studio in Turin, Italy, where he practices law. And in addition to his practice, he has been very active in UIA. He's one of the officers of our Health Law Commission, and we are so privileged to have you with us today, Diego. Thank you for making time.
Thanks to you. Greetings from Italy. As Italian, we gained a place in this very nice meeting, regretfully, because we had a role, as we said, of Western Sentinel. We were the first one in the West to test the virus. We thought to be well prepared. If we look to statistics, we understand that Italy and Spain, strangely enough, are supposed to be the best countries in terms of a health system, especially because our health system is also totally free of charge. So we have no problem of how much it costs. If we look to the result, we realized, if not to be the worst, not to be in a good position. In a situation which is exactly the opposite to the one that Dr. Takahashi showed before. Our reaction time was not so good, but especially we had an enormous number of tests. Let's imagine that in a single region in Italy, in Veneto, we had twice the test you did in Japan, 400,000 tests in Veneto only, with a tactic that was not the same in all around Italy. If we can come back to the slide before. Well, looking to the ugly before, to the sad things, why we had a late reply. COVID arrived in Italy in late February. We had a lesson learned, maybe not so many from China, but we didn't use this experience. probably because parallel to this, we had also another pandemic of fake news. Probably Larry talked about the role of the politics. Also in Italy, we have a sort of negationism approach from the political guys. Let's imagine that in February, we had still political people shaking hands and drinking wine in Milan. That was thereafter the more affected area. In Milan, the mayor launched a motto saying, "Milan never stops." So the approach was not exactly the right one. In terms of expert, probably we have not heard too much to the expert, and our problem is not to have a single president, bad or not, a single expert, medical expert, bad or not. In Italy, we have plenty of them, so not necessarily with the same approach. So looking to the public health system, our problem was mainly that the system was not able to face the stress test. We had a poor support by territorial system. We tried to copy the Chinese idea of an emergency hospital of Fangang, but we did this in the Italian way. We created big replica of the same hospital we have, the hospital invaded by patients, with all the medical doctors affected by COVID as well. And when they have been completed, the first wave was already over. So we have a nice hospital completely empty now. And surely also the population didn't help too much, a poor civil sense. Also in terms of emergency legislation, we are exactly the opposite of Japan. We have not clearly a right of the state to order the lockdown, but we had the lockdown. And thereafter, we had a very complex and confused emergency legislation. Too fast. Among the ugly, of course, we had the number of deceased people, because what we have in common with Japan is the number of elder people, especially the number of people that died in nursery institutes in Italy, and that to a certain extent were abandoned. Among the bad things that we had to face, the first one, surely, thinking about the too many deaths you have in Japan, the great resources you have in US, is that for the peak, we had a problem of lack of resources. So our medical doctors involved in the association of anesthesists, they have to come out with a very detailed and clear, and to a certain extent sad document with legal but especially ethical implication, saying that in case of lack of resources, the rule is not first come, first served, but we have to consider the age of the people, the disease. So we are really like in a war. We have to choose the patient to be followed. What is the good? Well, I took the liberty, being an Italian movie, that was the basis of our vote, to exactly take the opposite. Well, the good is that complex system like the health system take benefit from shocks. So we are confident that we can change the rules. Differently from Japan, we have no legal constraint to the use of telemedicine. We are using it enough, especially for chronic patients. So we really think that a new era is starting on this, on telehealth. Some reality invested in advance, which is good. And we are confident that a reformed health system, what didn't work before, could be the guarantor of the economic resurrection. In this, taking telehealth in the larger sense, and Josh said, not replacing the traditional medicine, but supporting. We want to have our apple a day, be sure, and I want to see my doctor probably more than I see today, because my wife is a doctor and we are living in separate rooms, which I don't like. So looking to this slide, which is not mine, but became very famous in these days, we used telemedicine. In Italy, we used it very much for the first wave. Regretfully, many doctors were affected by COVID because our hospitals were overcrowded. We have been unable to stop the people to come to hospital to select. We used telemedicine to replace the doctor we didn't have. You can imagine we had more than 150 doctors died for COVID reason. Basically, the people who died in South Korea for this. Unbelievable. We will use it also in the future, no doubt for COVID, but especially we want to use this for the people we were forced not to follow during this period, because a great problem also for us as a lawyer and as litigators maybe are all the people we are not able to follow, and that before COVID were urgent patients we had to follow. All the doctors were concentrated, all the hospitals were concentrated on critical patients with SARS-CoV, and the other patients were put aside. Many of them were not confident to go to hospital. We have not the statistics of all the people who died at home for heart attack or for other disease that normally we are able to take in time. The third point, which is very important for the super old countries like Japan, like Italy, Finland, Germany, European countries in general, are the chronic patient, which has been forgotten, leave alone even too much in this period, and surely telemedicine could help on this. And probably all the time along, what will be important will be also to follow from a physical point of view, saying that we are present, the doctor is there, for all the burnout we had, all the depressed people we had due to the pandemic in this period, which is surely a problem. And telemedicine can make the doctor more present, is there, maybe not physically, to make better the same job every day. So what is good in our vision? It's good that telemedicine could complement the ordinary medicine, starting. It's strange because telemedicine was created, like Josh correctly said, to follow patients far away and to involve them. Now we are using it because it's distant. It's a period in which we can come out, but please stay alone. Social distance is recommended also with the doctor. And these in different phases. not just the cure, but the prevention, the access online, so make the patient more responsible for the diagnosis. Probably this will create less liability for the doctors, more involvement of the patient, more difficult problems with the machines, because it's also the place of artificial intelligence, of this chatbot we are using. The third point remains surely the care, also because it helps a lot to avoid during pandemic the contagion, to make a fast diagnosis, and to keep the patient isolated. We have seen also part of the future. We have seen many robots going through the hospitals in these days, also because the doctors disappeared in many respects. And to grant a follow-up of the patient, the checkup we need, the chronic patient, not to replace, but to make better the intervention of the doctor. So surely this will be the good. Okay, but I leave a space to the question that the colleagues generated before. Thanks.
Thank you, Diego. Thank you, all panelists. So if I may turn quickly to the questions. One of them is from Barbara Gislason, who says, quote, want a sequel to this excellent program, including India, China, and France. This is really good. Well, I didn't ask her to say that, but I thank her because it allows me to tell you that, in fact, we have sequels planned. On May 14th, a similar seminar to this will be held in French with different French-speaking speakers, which is good, since if you had to hear Josh and me try to speak French, it would be very embarrassing. But we have that panel held by by Eliana Silvia de Moraes. Then after the May 14th presentation, on May 18th, there is a UIA Insurance Law and Health Law Commission on issues including legal immunities and waivers during COVID-19 and insurance coverage. I dare to say during that seminar, you'll hear more about why the distinction Josh drew between SARS-2 COVID versus the disease of COVID-19 may make a practical difference in insurance policies in the US. And then finally, we are going to have a town hall session. The date hasn't been set yet. It will be in June. It will be more of an interactive seminar, and we have people committed from India, Australia, Spain, Africa, and the US. If you'd like more information about that or any of these, of course, communicate with UIA, or you can email me mulligan@janmulligan.com. Next question. Thank you, Barbara, for that question. Ian DeFritas from England says, just a quick comment. In the last 2 hours, in its latest response to COVID-19, the UK government has announced it will introduce a program to look at more innovative delivery of healthcare, including telemedicine, remote monitoring of patients so that they can have hospital level care delivered directly to their homes. We will see. Thank you, Ian. Talk about timely topics. That's amazing. A few more questions. Rafiq Nofal has two related questions. One, how can the developed countries like Egypt and African countries give a hand and help to face COVID-19? And why can't we from here, I assume that's Egypt, make worldwide team to cooperate always to face crises like this? I open that up to the floor. Is there anything that Egypt can do to help us in New York and California and Italy, Tokyo and elsewhere when we need it? Dr. Friedman?
I'll start off if I can.
Please.
But again, I'm a loud New Yorker. You know what? I'm always willing to learn. And I'm very fortunate from this panel that we're covering 10 time zones. And I don't know how many continents. But you know what? I've learned from all of you, and I appreciate that. And by the way, can I make a joke?
Is it funny?
It's not really
Judge
funny.
afterwards.
You know where I'm going with this? Is Diego told me I had to learn how to cut my hair. So, you know what? He was right. So it's not perfect, but it's not as bad. Well, I hope it's not as bad as when he first saw me 2 weeks ago. You know what? So we're moving forward.
Yeah, one comment I would make, Jan, is one thing that we clearly learned from this pandemic is that the world is interconnected in terms of infections. And in fact, it spread worldwide so rapidly because we are interconnected. So relative to the comment about how can Egypt help, without knowing a lot of facts, I'll just sort of give the opinion off the top of my head, which is that Egypt, I don't know the public health system intimately in Egypt, but I think that every country needs to be responsible for accurate reporting, testing, tracing, because the way to stop this is to test, trace, and sequester patients who are infected. And without that, it's just going to keep on growing and growing. We need to put a stop to this before a vaccine is discovered.
Other comments?
My only comment is, while it unfortunately takes a virus hours to move from countries, information we can move in seconds or milliseconds. And that's why this is important.
Thank you.
Well-
Yes, Dr. Takahashi?
Yes. After pandemic, it is difficult to help because we are now under a state of emergency. But we never expected. We have never expected that COVID spreads so rapidly. And I learned that it is important to prepare for the second wave of COVID. And in this sense, I think there is something that we can do for Egypt. Thank you.
Thank you very much. There is a question from Ruben Acosta. I'm sorry, I can't see your last name on my screen. It's in Spanish, and if I've translated it correctly, it asks if the pandemic has also saturated the courts in our respective countries. In the United States, from state to state, it's different. In California, from county to county, it's different. Right now, the San Diego courts, the state courts, for example, are closed. They're not even accepting any filings. People are sending their lawsuits, their motions to be filed to a private company that does electronic filing. And as soon as the court opens, then everything will be automatically filed in the order in which it was received. Some of the counties in California, state courts, have started opening in limited amounts. Federal courts are hearing motions. Our Supreme Court was hearing motions and audio over the telephone. I don't know if it had visual to it as well. So that's the state in the United States. I'll let others comment as well, but I would say to you that I don't mean to keep plugging our other programs, but since you asked, the program on May 18th, UIA, Insurance Law and Health Law Commission, will have an appellate judge from Minnesota, Justice Peter Reyes, who will be addressing this very issue. And so I would ask you to join us on the 18th for that lively conversation. Any other comments about the courts in other countries? Okay then.
I will, do you want to go in time sequence? Because Shigeki is way ahead of us at like 1 in the morning. So let's let him get to sleep.
One final question, if I may. Dr. Shigeki, thank you for bearing with us.
Thanks.
Good night.
Question from Robert Hurst that he'd like Dr. Friedman's comments on. Writes, the U.S. crisis has two causes. First, preoccupation with Brexit and cuts in hospital expenditure that were left them unprepared in terms of lack of PEP, ventilators, facilities for testing. Secondly, we, UK, should have closed our borders at an earlier stage. Dr. Friedman's comments would be appreciated.
I agree wholeheartedly with those comments. Unfortunately, well, I do know the English healthcare system fairly well, and you have the national health system is quite good in Britain, but this is about being prepared. This is about funding public health. I mean, if anything, you would think that there's a wonderful book, by the way, about the influenza pandemic of 1918, if anybody's interested. You would think that the world would have learned a lot of public health lessons from a decade ago when there was a pandemic that swept the world and killed many, many people. But if anything, this is really raising the influence, the importance of public health systems and being prepared for this kind of thing. Doctors, with a public health system that's unprepared, there's just so much that doctors can do. I think if anything, this is hopefully set some precedents for keeping all of our countries, regions prepared for what could come next. We got to get out of this first, but hopefully we're not going to forget about this very quickly and make sure that we go into this prepared. In terms of Brexit, basically taking people's attention away from this, hard for me to comment on that. I do know that was very distracting, but nonetheless, there's a nation of people to take care of, and we're all struggling with being unprepared, at least in this country, and unfortunately in England also.
We also hear from Robert Hurst that the majority of UK commercial hearings are currently being held by Skype. I see no other questions, although I am grateful to see that Rafiq Nafel has thanked us for this and promises to be involved in the future and attend more of these to help the world's lawyers and hopefully physicians also communicate and learn. Thank you, Rafiq, for that comment, and we hope to see you at the other sessions we've mentioned. Anything else from our panelists? All right, then we'll let Dr. Takahashi go to sleep. It is now, past 1:30 in the morning for you, whereas here in California, the sun has just risen. Thank you all for a wonderful panel. Please, people that are on the line, give your evaluations to UIA so that we know we're appreciated and we can continue to do more programs like this in the future. Thank you all. Be well, stay safe, and see you in another webinar.
Thank you very much.
Thank you. Thank you for participating.
Good afternoon, good morning, and good evening.
Thank you. Bye-bye.
Bye now.
Bye-bye.